If we can close the doors and invite the people in the halls to come in. Okay, thank you. We're going to be talking about medical therapy of carcinoids, a subject which is challenging and you've heard a little bit about this morning. We're going to go into in more detail. How do we make the slides function? No? No? It's the one that was labeled 250. The program's a little bit behind time. There we go. Okay, so we're going to talk a little bit about medical therapy of carcinoids, systemic therapy that goes through the body and treats carcinoid disease. Before we begin, I just wanted to remind everybody of an extraordinary lecture that the late Charles Mortel gave at the American Society of Clinical Oncology, known as the Karnofsky Lecture, one of the most important oncology addresses that happens each year at the ASCO meeting. Charles Mortel from Mayo Clinic said the following: "One would hope that the development of such methods of tumor-specific therapy will proceed rapidly, since certainly the necessary technology is now available. Our current methods have been devised in a crude and empiric fashion. Nevertheless, we are seeing response rates that reach to 90% with median durations exceeding to 2 years. We are ever so close, and it is reasonable to predict that the gastrointestinal neuroendocrine tumors will be the next medically curable cancers." Dr. Mortel said this in 1987, and now 21 years later, I think we're seeing that we're getting closer and closer and closer to eradicating these diseases, to giving people much longer survival, much greater chances of remission. And I think we should keep these words in mind. I'm just going to give you a very brief overview of where we stand with chemotherapy. We have a panel of outstanding speakers who are going to talk about most of these issues in detail. And then at the end, I'm going to talk about some particular clinical investigations that I've been particularly involved in the last year. One thing I should tell you about response to chemotherapy is that the way oncologists judge response to chemotherapy is by reduction in at least 50% of cancer, which is known as a partial response. Oncologists are very hard on themselves. When people have less than 50% response, in general in oncology, we call it a non-response. However, smaller degrees of response turn out to be very important in neuroendocrine tumors, and even slight shrinkages in tumor or stabilization in disease, so-called progression-free survival, where you can live for a long time without tumor growing, greatly extends life and is very valuable. When I show you these slides, then when you see progression-free survival, it's not on here. You're going to see partial response, or PR, which is the way oncologists tend to judge these drugs. And you'll see for most of them, those response rates are not as high as we would like. But nevertheless, drugs can be used in a skillful sequential fashion, as you'll be hearing about a little later from Dr. Koka. Okay? So this is just giving you an example of clinical trials. Major shrinkage of cancer from octreotide, lanreotide are very small, a couple of percent. Interferon alpha, we've heard 10 to 15% average. Many studies have been done. Interferon combined with sandostatin, Dr. Oberg will be talking about in more detail. Looks a little bit better. All kinds of chemotherapies have been used with various degrees of success. Randomized trials have been done between different kinds of chemotherapy, again with varying degrees of success, but in carcinoid tumors, very few drugs even reach 30% in major tumor shrinkage, more than 50% shrinkage, but all of these drugs tend to have effects in controlling tumor growth. Pancreatic neuroendocrine tumors, as we've heard, have a higher response rate, And when you use the same kinds of chemotherapy in pancreatic neuroendocrine tumors, you can have responses of 50%, 60% or more on all of these clinical trials, and response durations that often can last for even several years in people that are fortunate. Biologic agents have been tried, all kinds of different combinations of tyrosine kinase inhibitors, anti-angiogenic drugs, and we'll be hearing about more of these in some detail. Dr. Philippe Rudzinski is going to be talking about lanreotide in more detail, so I will go over this quickly, but it's a new type of somatostatin analog which has some potential advantages over octreotide that we'll be hearing about. SOM230 LAR, also known as pasireotide, is a somatostatin analog that I wanted to talk about in a little bit more detail. This is a drug that has improved somatostatin receptor binding profile compared to octreotide. It binds not only to the subtype of somatostatin receptor called SST2 and SST5, but also binds to two of the other subtypes and binds with a higher affinity. So it's a very potent type of somatostatin analog. A phase 2 trial of using this agent in carcinoid tumor with 45 patients was conducted to evaluate flushing and diarrhea, the carcinoid syndrome. And in 25% of patients approximately who had flushing and diarrhea resistant to octreotide, they were able to get a response to pasireotide or SOM230. Toxicity was very similar, and you'll be hearing more about somatostatin analog toxicity later this afternoon. There's a large study of pasireotide LAR, the once every 4-week subcutaneous injection, which I've been involved with along with Walter Koka and a multi-center, multi-national study with 300 micrograms of SOM230 LAR, also known as pasireotide, given to assess tolerability, followed by either 20, 40, or 60 milligrams IM every 28 days in a randomized clinical study. The efficacy, tolerability, and blood levels, pharmacokinetics of the medications were then evaluated. This study was done in people with carcinoid tumors of the digestive system who had elevated levels of chromogranin A and or 5-HIAA. And the carcinoid syndrome was uncontrolled by the currently available somatostatin analogs, either octreotide or lanreotide. The pasireotide LAR was quite well tolerated. 60% of patients had one or more side effects, although these side effects were generally mild and were typically things like diarrhea, nausea, and steatorrhea, injection site reaction, asthenia, which is just a feeling of malaise and not feeling too well. Elevated blood sugar, however, occurred in 12%. This is one toxicity which is a little bit more prominent than with octreotide. In these patients who were treated with pasireotide, 12% had an elevation of blood sugar, 7% had a diagnosis of type 2 diabetes mellitus, and the hemoglobin A1C, which is a measure of glucose metabolism, and it tends to be a sensitive way to diagnose and follow diabetes, increased from a mean of 5% at baseline to 7% at 3 months. The pasireotide controlled carcinoid syndrome, which was uncontrolled with octreotide or lanreotide. This is the pasireotide LAR. Frequent side effects were mild gastrointestinal disorders, injection site reaction, asthenia, and hyperglycemia, generally quite well tolerated. All 3 doses of drugs appeared to be quite good, and it's not clear that there are differences between those. And results from a phase 3 trial of this agent are awaited, and studies are ongoing. I'm going to briefly mention the second exciting new drug for treating neuroendocrine tumors, known as atipramod. Atipramod is a new oral drug for treating neuroendocrine tumors. It's the first drug in its class known as an azospirine It's a unique kind of a chemical with a lot of anti-cancer actions. It increases cell death, also known as apoptosis. It is anti-angiogenic. It starves out the blood vessels supplying the tumor. And it inhibits some of those signaling pathways that stimulate cancers to grow, which we've heard about earlier. 16 patients with advanced neuroendocrine tumors were treated on not neuroendocrine tumors, but just 16 patients with advanced cancer were treated on a phase 1 trial of all comers to see how this drug would work. This trial was done at MD Anderson, where there are a large number of neuroendocrine patients, and it turned out that 6 out of the 16 patients had neuroendocrine tumors. This is pretty unusual in a broad phase 1 trial. Usually most patients in such a situation would have colon cancer, lung cancer, breast cancer, something more common. But the amazing thing is that 5 out of these 6 patients had a clinical benefit. 3 out of the 6 had tumor regression. 3 out of 6 had improvement in carcinoid syndrome. There was only 1 out of 6 who had no benefit that can be seen from the drug. So this was very hopeful early data from a phase 1 trial. This led to the development of a phase 2 trial, which was presented at ASCO this year. Dr. Sung is the first author, and Coles and myself. These patients coming largely from the New York practice with Dr. Richard R.P. Warner, Dr. Sung, and California at Cedars-Sinai. The objectives of the trial to evaluate the safety and efficacy of atipramod in low to intermediate grade neuroendocrine tumors. These patients all had progressive disease or had carcinoid syndromes which could not be controlled with octreotide. It was a phase 2 multi-center study. The atipramod was given in a predefined dose escalation scheme because it was known to be a drug that can build up levels in the blood that can lead to liver toxicity. So to prevent that from being a complication, as people were on the drug for a longer time, the dose was reduced in a planned fashion. Patients who progressed or had uncontrolled syndrome were put on study. The inclusion criteria were low or intermediate grade neuroendocrine carcinoma, so this included both carcinoids and pancreatic neuroendocrine, metastatic or unresectable neuroendocrine tumors that had progressed in 6 months, and they all had a good performance status, meaning that they were out of bed ambulatory more than half a day. This was the details of the dosing scheme using a planned dose reduction and careful monitoring of liver function. It had remarkable results on this study for control of cancer. The CR, complete response, and PR, greater than 50% reduction, were not seen. However, stable disease, meaning less than 50% reduction or stabilization, occurred in 92% of patients, and only 8% of patients had progression. So it seemed to be a quite active drug in preventing tumor from progressing. And at the end of 6 months of therapy, approximately 76% of patients had remained progression-free. And at the end of 12 months, 50% of the patients are still on trial and progression-free. Again, looking very promising. Some patients had a dramatic reduction in carcinoid syndrome that was previously refractory to somatostatin analog therapy, with dramatic reduction in the amount of daily flushing with consecutive cycles of therapy. 6 patients had liver toxicity, which was felt to be due to this atipramod. All involved the AST and ALT liver enzymes becoming elevated. 3 also had mild elevations in their bilirubin level in the blood. The abnormalities in liver function resolved in every patient, and 2 patients were able to resume atipramod after the liver function problem resolved without further difficulty. No patient had a fatality from the liver toxicity. There were 2 fatalities on the study, but both were in elderly patients with sepsis that was felt to be unrelated to the study medication. So it looks like it's a well-tolerated medication. It gives a whole different drug which can be used with a different mechanism of action, potential for long-term use, with 8 patients being followed so far over a year without a problem, improvement in carcinoid syndrome, reversible liver function abnormalities in some people, and we're still trying to define if there are certain situations, for example, prior hepatitis or chronic active hepatitis or other things that might predispose to this type of a situation. And because of its minimal toxicity, except for the liver toxicity in rare people, it certainly gives potential for synergy and combination with both other biologicals and with chemotherapy. And phase 3 trials are now ready for action with this drug. Last thing I wanted to speak about briefly was the use of a drug known as RAD-001, or everolimus. This is an mTOR inhibitor. mTOR is a central regulatory enzyme inside of cells, represented by that little yellow sun-looking object inside the cell. That's called mTOR. mTOR controls cell growth, cell division, cell metabolism, blood vessel formation, whether or not the cells die. It affects all kinds of things that involve cancer cells growing. It turns out that a very high percentage of neuroendocrine tumors have a mutation leading to enormous increases in the amount of mTOR in a cell, and this is one of the things that's driving the cancer cell to go crazy and divide too much and grow too much. And by inhibiting mTOR, you could reverse the process and the cells can die. So it gives a biological therapy directed at this central regulatory protein. Dr. Yao et al. Just published a very nice review of a phase 2 study using this drug in Journal of Clinical Oncology last month. It just came out, and I'm just going to give you a little summary of the new data on RAD-001. There were 5 milligrams or 10 milligrams were used, 30 patients each. He did it with 30 carcinoid patients and 30 pancreatic NET patients. There was a 20% partial response rate, meaning at least half of the cancer had shrunk with this medication, which is a major response. Stable disease in another 70%, so we're now talking about 90% progression-free. It turned out on this study 8% had progressive disease. And the progression-free survival was 60 weeks median, where people were able to take an oral pill with few side effects and be able to have control for a long time. And many are going even past 60 weeks. That's the average. Okay? For people that were stable at the time they started the drug, the progression-free survival is 74 weeks. For people that had growing disease at the time they started, progression-free survival was 50 weeks. So that even in the worst prognosis group, it still seemed to be quite effective. Median survival has not yet been reached. 70% of patients with elevated chromogranin A had at least a 50% drop in blood level. Ki-67 measure of rate of cell division decreased from an average of 6.7% down to 2.6%. There was a question earlier today about whether you can sometimes have changes in rate of Ki-67. Well, not only can there be a discrepancy between a primary tumor and a metastasis, but as you see, chemotherapy could even change the rate of cell division when the chemotherapy is working on that item. Toxicity was generally mild. Mild mouth sores were the most common thing. And major side effects were occurring in less than 10% of people: diarrhea, low phosphorus level, low blood counts, pneumonitis, which is an inflammation in the lung that happened in rare people and needs to be followed and treated if it occurs, but it's not a common side effect. On the basis of that data, there have been 3 studies which have been initiated, popularly known as the RADIANT studies, RADIANT 1, 2, and 3. RADIANT 1 was a study in pancreatic neuroendocrine tumors for people that had not, for people who were getting either RAD alone at 10 milligrams per day or sandostatin LAR in addition to the RAD-001. The RADIANT 3, which is the study that followed that and which is open and is accruing patients at multiple sites around the world. We are one of the sites in the United States at Cedars-Sinai, is a randomized trial where people are randomized to one of 2 arms. One group starts out with RAD-001, 10 milligrams a day. The second group is randomized to a placebo with the understanding that at the moment there is disease progression, they will also get active open-label RAD-001. So every single person who's on the study gets RAD-001. Half the people get it on day one, and half of the people get it, for example, 3 months later if the disease were to progress because they were on a placebo. But this way it will clearly show the benefit of the medication. Okay. The objectives of the study are to see how the RAD-001 prevents cancer progression, and also being looked at is response rate, duration of response, survival advantage, and effect on chromogranin A and on blood levels in patients with pancreatic neuroendocrine tumors. These patients who are going on study have unresectable pancreatic neuroendocrine tumor and tumor progression in the past year. Pathology is lower intermediate grade, not the true high-grade pancreatic neuroendocrine tumors. Diabetes mellitus needs to be controlled if people have it, but it's not a reason not to be on the study. And people that have active liver disease on the basis of cirrhosis or hepatitis are excluded. In addition, there's a RADIANT-2 trial, which is the same study, almost the same design, in people that have carcinoid. That trial has recently been closed to accrual, and it's too early to analyze the data, but that will be coming shortly. This is the RADIANT-2 trial for carcinoid patients. And what I'm going to do now is to turn over the podium to our illustrious panel here to speak about various aspects of systemic management of neuroendocrine tumors.